it's easy just to give everyone a B-splint. It's easy, but then you'll get failures. And then you think, why is that? It's because you're painting everyone with the same brush. So what I like is putting some logic, some science, some experience behind it to come up with a little system or a solution.
That was Dr. Jaz Gulati. I'm Dr. Omid Azami, and you're listening to another episode of Noobie and Friends with the Noobie Dentist Podcast. In this episode, I sat down with my good friend and host of the Protrusive Dental Podcast, Dr. Jaz Gulati. Dr. Jaz is a general dentist in the UK with a special interest in ortho restorative dentistry and the conservative management of TMD. In this episode, we cover a lot of broad topics, including management of work-life balance, the management and dealing with the trials and tribulations of everyday dentistry, and how to reduce the variability in our work and to make our work more enjoyable. And we also spend a lot of time talking about occlusal splints, diagnosing, prescribing, and management of patients that present to our practices with worn dentition with extraoral symptoms of TMD. And we covered this topic in quite a fair bit of depth, so I hope you guys do get a ton of value out of it. For those interested in learning more, Dr. Jaz is running a splint course. You can head over to splintcourse.com, and you can use the promo code Noobie, Noobie, for a 10% discount on this course, thanks to Dr. Jaz. And if you're interested, you got to do this quite quickly because the next round of enrollments ends on November the 24th. So if you're interested, head over to splintcourse.com, use the promo code Noobie at checkout for a 10% discount, or alternatively, you can find the link in the show notes and that'll take you directly to the course. This week's episode of the Mini Implant Audio Residency is brought to you by my good friends at Mordent. Mordent is your proudly Australian-owned and operated partner, driving the charge forward in integrated digital dentistry. Being the only fully integrated local dental company, Mordent offers world-class education, equipment, products, solution, and support. The Mordent team of over 50 specialists are helping thousands of Australian practices to seize the opportunities in digital dentistry, transforming treatment for their dentists and the patients alike. Whether you're seeking to upskill through education or are considering implementation of digital dentistry into your practice, or just looking for some advice, I highly recommend reaching out to the Mordent team. Visit www.mordent.com.au to find out more. I will include their information in the show notes for those interested. As always, if you're new to the Noobie Dentist Podcast, thank you for checking us out. Be sure to head back and check out the previous episodes that I've done on the podcast. I've had the privilege of having some amazing guests on the podcast over the past couple of years. If you're returning, thank you for your ongoing support of the Noobie Dentist Podcast. I hope this podcast is full of value for you. And if you are getting value, please head over to iTunes and give the show a 5-star rating. These ratings help the show get more traction within the dental community. Without further delay, I hope you enjoyed this interview with Dr. Jaz Gulati. Welcome back for another episode of Noobie and Friends. I'm really delighted to be joined by a fellow podcaster today, Dr. Jaz Gulati out of Reading, United Kingdom. Dr. Jaz, you had me on your podcast and that was a great experience. And I had to sort of get you to come on. I know how busy you are with your time. And so I really do appreciate you giving the time to come on the Noobie Dentist Podcast and talk a little bit about yourself, the podcast. We'll talk a little bit about a topic that's become sort of important to both of us, I think, in terms of designing your career, work-life balance, and sort of being the captain of your own ship and how that goes throughout your career and how you can be fluid in that situation as well, which we were talking about a little bit in the pre-interview. And I know your sort of early passion, I know obviously career interest and topics of dentistry also change, but I know you have a strong passion in TMD and occlusion and night guards and things. So I'll pick your brain on that a lot because, and I'll get your comment on this later on. Actually, I've noticed during COVID lockdowns, the stress, and everyone's just coming in with cracked teeth and grinding and clenching. So I think it's a very topical topic as well to talk about today. So Dr. Jaz, thank you for coming on. Really appreciate it.
Oh man, thank you, Omid, for having me on. And for those who haven't listened to the Champion Mindset episode we did on Protrusive, thanks so much for coming on. I mean, your listeners are already used to you sharing all your nuggets and all the things that you read, but you really help my listeners to really master their mindset. So that was a really great episode. So thanks so much for doing that for me. And thanks for having me on today on your podcast to talk about all these things from designing your life, the origins of the podcast. And then, of course, we can get to the nitty-gritty details of occlusal appliances. I'm going to slap you for calling it night guard.
That's good. That's a good start. That's why I'm here to learn. That's what I called this Noobie and Friends, because I want to sort of, use what my friends have learned and, pick that knowledge and kind of bring it to my own sort of career. And that's one of the benefits of being a podcaster. You get to be lazy and bring CPD or CE to you rather than going out to search for it. So why don't you tell us a little bit about yourself, first of all, and sort of the origin story, if you will. And then we'll talk about the Protrusive Dental Podcast, which I'm a huge fan of. And then we'll kick on from there.
Yeah, sure. So I'm Jaz Gulati. I'm based in the UK. I qualified from Sheffield in 2013. And then for those who are familiar with the UK, you do like 1 year, which is like a bridge year. Like you're like a junior dentist in a practice. So everyone does that. And at that point, I was really in my head, like I wanted to be this restorative consultant. So I wanted to be someone who is the highest guy at the hospital that, people, all the complex cases get referred to and do these full mouth rehabs and stuff and treat oncology patients. But then after doing some stints in hospital and seeing all the bureaucracy, the politics, the absolute nonsense that goes on there. And then actually I learned that true innovation, Omid, happens in private practice.
Yeah.
So then I had to get out of the system in the UK. Won't go too much into that. And then I moved to Singapore, which was amazing. Oh, wow. It was like me and my wife moved to Singapore. We were working as dentists. At the same time, we traveled to Bali, India, Australia, went all over on lots of holidays, Bangkok. It was a great like travel experience, but also a work experience as well. And then we came back because my wife got homesick. Now, here's the interesting thing, Omid, how the podcast comes into this is that people in the UK, like dentists in Australia, like everyone kind of knows each other, right?
Yeah.
So everyone in the UK podcasts or in the UK forums, the dentist forums, as soon as someone mentioned on the forum, does anyone know a dentist in Singapore? Like how can I work in Singapore? How can I work abroad? So everyone started tagging me. So when I used to have this like hour-long commute, I'd be on the phone to a different dentist every evening, okay, telling him the same thing. Yeah, this is how much you earn. There's no exam. Everyone speaks English. It's amazing. That kind of stuff.
It's a good tax situation too, I think, isn't it?
It's a great, oh my God, tax was amazing. Put it that way. Yeah. Like, I've never smiled paying tax before, but at that time I was definitely smiling paying tax. You're very right there. But every day I was on the phone to someone else. And I thought to myself, wow, this takes a lot of my time. I like to listen to my audiobooks. I don't want to have to like speak to a different person for like 30 days in a row, telling them the same story. I thought, if I could record everything I want to tell everyone about Singapore in audio and distribute that, and then I found out these things called podcasts exist. And that's when I started to listen to yours as well, all those years ago, and you've been doing a wonderful job. So I put the first one out, it was all about dentistry in Singapore. And then I started to, let myself out, my own clinical interest, how much of a dental geek I am. And there we are. That was the birth of the Protrusive Dental Podcast.
That's awesome. It's great that, everyone has these like stories about how things kind of get started. And then it's amazing always to like look back and see how far things have come from like that first episode you did to now what you're doing and amazing content and the video around it, the production around it. So it's definitely amazing to see the progress, not just in your podcast, but just like the whole dental space podcasting wise. I remember when I started, I almost knew every podcast that was there. There was like maybe like 10 dental podcasts, and you had the big players, and then I kind of had everyone that kind of started at a similar time as me. And a lot of those who started at the same time I did like don't sort of exist anymore to stop like making episodes and things. But now I don't even know how many dental podcasts there would be. There would be like over 100, I would say.
You're right. And Omid, the funny thing is, the more I read about podcasting, because I've done some podcasting courses to improve myself as a podcaster where I can. And what they're saying is that podcasting very much is still in its infancy, and more and more people are still discovering it. A lot of dentists I speak to still don't listen to it, which is why I guess I went down the YouTube route as well to get my content out there. So as well as Apple Podcast, Spotify, etc. People, there's a lot of people who just exclusively watch the videos and stuff, which is another way just to learn. And I think YouTube, a shout out to YouTube, man. I learned how to remove wisdom teeth initially on YouTube. I'm sure
YouTube University, as they say. Yeah,
exactly.
No, that's great. And so tell me a little bit about sort of the for people who aren't familiar, maybe in Australia, who aren't as familiar with the Protrusive Dental Podcast, sort of like the genre, or like what does it cover mostly? Is this sort of more clinical, more business for people who aren't familiar with it? Is it kind of full sort of scope?
Well, I think there are so many dental podcasts which are focused on business and money and insurance and this. Mine's definitely not that. Like mine's like really geeky, extremely clinical. We have the odd non-clinical one, but it's very much a very geeky, clinical, nitty-gritty podcast, from a recent episode with Neki Jamal on wisdom teeth to occlusal equilibration. And then the theme is that, I can't go more than 3 episodes without putting something inclusion, having an inclusion guest. Okay. So it's my passion topic, TMD, occlusion, bruxism, that kind of stuff. So that's the main focus, and hence why with the name Protrusive, I wanted something that was forward thinking, and hence Protrusive was the only option for me, man.
That's a catchy name, and it feeds into, like, you pick up on the dental nerds, right? They'll be like, oh yeah, I like that, and they'll kind of come to it. So that's great. All right,
so attract your own tribe, right? So it's the Protruserati have self-selected themselves as these dental geeks who have an affinity towards occlusion.
Yeah, no, and you've done a great job of building that community around it, and I'm sure a lot of people are getting a lot of value. So for those listening, maybe if you're in Australia, you're not familiar with Jazzy, I'll obviously have the links and everything in the show notes and all that. You can check out his podcast and see all the amazing guests and things that you've had on. What are some of your goals for the podcast? I don't want to put you on the spot here, but like in terms of fast forward a couple of years, what are you hoping this podcast, the Protrusive Dental sort of entity becomes?
I think you'll be able to relate with this as well, Omid, is that the best part of what we do is on the side, because we're very much wet-fingered practitioners. We're super busy with that. We have friends and family and all the social things to do as well. But what the podcast gives us is space to express ourselves, a space to create, but a space to inspire. And I love getting these messages that, I started listening a year ago and it changed my perspective of dentistry, or it reignited my passion in dentistry. I'm sure you get flooded with these as well. And like recently, we did one on how to make extractions easier and the importance of sectioning and elevating teeth, which I don't think young dentists, especially in the UK, do enough. I don't know what the situation is like in Australia, but dentists, young dentists are afraid to section and elevate for whatever reason. So I think that makes your extractions much easier. And then like 3 days after posting it on YouTube, this young dentist, 1 year out of dental school, commented saying, thanks to this podcast, on my last day as a junior dentist, a DF1 dentist, I was able to take out this tricky molar, doing something I'd never done before, i.e. section elevating, thanks to this podcast. And it's that kind of feedback that I love. So my aim is to, as many people as I can get to fall in love with dentistry again. That's the aim.
Yeah. And we were talking a little bit beforehand in the interview that, this is like the best time to be a dentist. And I really, sometimes when I'm taking out these old amalgams and I'm jealous because I have to like try and put a rubber dam on and isolate these margins to, this like so technique sensitive composites and stuff that we're doing. And I think back, oh man, dentistry would have been so easy back in like the 60s and 70s. We were just like packing tough iron amalgam. But truly though, beyond like that small niche of it, in terms of learning, community, the baseline standard of dentistry sort of around the world, because of social media, because of podcasts, because of YouTube, it's just like it's such a higher floor of what acceptable dentistry is nowadays.
Absolutely, Omid. And you get exposure to things that if you close yourself off to all these things, you'd just be very narrow-minded. But because of all this, and I call it noise, because it is noise, because there's so much of it now, right? You're getting bombarded. It's like over stimulus, and it's a double-edged sword, because I know some dentists who get affected in terms of their mental health, because they see all these amazing cases constantly. Oh, this dentist is doing smiles all day long. This dentist is living their life. They post up this full mouth rehab, then they're driving their Ferrari or whatever. and that's not what I mean when I say it's the best time to be a dentist. What I mean is, if Omid, if you and me needed help from someone on a clinical case, we are a click away, right? There's so much mentorship. There's so many helpful, lovely dentists out there who will always help out someone who's less experienced or just needs a hand. So because of that element, it almost accelerates your growth. It's like rocket fuel, right? So now we have this rocket fuel all around us. It is a double-edged sword, like I said, but I think it's never been a better time to be a dentist who wants to learn and grow. I think that's the main message.
No, I can definitely attest to that. I've personally been through that side of, a few years ago when I sort of moved back to Australia from Canada, I had to wait like 3 or 4 months to get like all my licensing and stuff sorted out. And I just couldn't be on dental Instagram anymore, because it was like every day I'm like at home and I see everyone, like you said, posting all these cases and stuff. And it's really starting to like sort of affect me in a negative way there. So I definitely I think people need to be careful and need to know sort of the work that goes on behind the scenes to produce this dentistry. So they, a new grad will think, oh yeah, I can wake up and prep for like 8 veneers, like on my first month out of dental school, not knowing the amount of work that's gone in, in terms of planning, in terms of the courses, the mentorship that these clinicians have had before they've started doing these kind of things. But you're right. I think if you're a willing participant, if you're not like passive, and if you're actively seeking out mentorship and things, best time to be a dentist for sure.
And I think that needs to be said. I'm so glad you mentioned it, Omid, because there's so much doom and gloom. Like we talked about on my podcast when you came on, like morale in dentistry in UK is quite low. I think it's improving a little bit, but it's quite low. And therefore, this message needs to be sent out, especially the new grads that don't worry. I know we had a tough couple of years in terms of your training as well, but help is all around us. You just got to open yourself up to it and you will find it.
Yeah. And technology is helping a lot too. I think with the aid of technology, the predictability of harder stuff is getting more like the band of like variability is getting less and less because you can do things more predictably with technology. So I think as that gets more adoption sort of, or becomes more affordable. So like every dentist, I know like the public stuff in the UK is a lot as well. There's public in Australia as well. But if the public sector can even adopt some of these basic technologies like scanners and things like that long-term, it'll have a huge impact in terms of one, like the amount of fun you have with the technology and the learning curve that goes with it, but also the work becomes more predictable, which is quite good. So I think there's definitely a lot of scope to learn and do things in a nice, safe, predictable manner so you get good outcomes.
Like we were saying earlier, innovation happens in private practice, hence why sometimes in these hospitals, they're late adopters to all these technologies. I mean, I think it's also not good to be too early of an adopter, right? But I think it's great with all the toys that we have available, which makes dentistry easier. And the scanner has been absolutely amazing. I don't know, are you scanning yet?
Yeah, I'm scanning. The only time I take like impressions now is pretty much if I'm just gonna make like a whitening tray or like a S6 retainer for someone as like an interim sort of thing. But and we'll get into it when we talk about the occlusal splints and stuff. Even we're like 3D printing our own splints now in our new practice that I'm working at. So it's pretty cool. All right, so let's get into the work-life side of things a little bit. I know this is a topic that we touched on your podcast a little bit as well, and I've sort of gone ups and downs with this where I'm working too much and then I get burnt out and I'm like, no, I need to like, take my foot off the gas and I'll cut down or I'll change sort of jobs for a bit. And then you fall back into the same old habits and traps again. So tell me a little bit about your journey with work-life balance, where you're at now and sort of what, I guess, like new insights you've had since you've sort of, shifted the work-life balance in terms of the life side a bit.
Absolutely. Well, I think the best way to describe it is phases. And I think in the initial phase, and this was like excessive, but I was breathing, living, sleeping, eating dentistry for the first 3 years post-qualification. Like I went to every single free course. We call it like Section 63 courses. Like there's loads of free courses, webinars. There weren't so many webinars then as there are now, like obviously 8 years ago because of COVID and stuff. But yeah, as anything that was there that was cheap or free, I was going on, right? And it was like, on a daily basis after work, I'd go to some sort of educational event because I was so hungry for knowledge. I was so willing to learn. And I think for those who are willing to learn, great things will happen. It will, elevate your dentistry big time. So I was very much learning, working like a dog. Then I was working in hospitals and also working on the weekends to keep my hands in practice, because the danger of working in hospital is you de-skill and you slow down, right? So I wanted to avoid that. So that was that phase. And then obviously Singapore happened, which was fun and stuff. And then I had like imposter syndrome because I'm like, oh my God, I'm about to go into full-time private practice, even though this is what I wanted. And I was working really hard toward attaining this. Actually going into private practice in the UK anyway, for me, it was like, oh my God, am I good enough kind of thing, right? Best move I ever did. I'm very much a general dentist. And I look back at why I do the procedures that I do now. And I think sometimes only when you look backwards can you connect the dots. So for me, it's like orthodontics. I like doing orthodontics. I did a diploma in orthodontics and I love anything inclusion, TMD. But interestingly, those were the two things that were my weak points during dental school. Those are the two things that confused me the most. Like at the ortho clinics, I was like, what the hell's going on? And then occlusion, TMD, I think we're all confused, right, when we come out. And I think personally that inside me is this kind of perfectionist personality, right? Like I hated the fact that I had this big weakness. So maybe that's why I've sort of, pursued this. But anyway, coming back on track on work-life balance, I was telling you earlier that having a child sometimes changes everything. So while my wife was pregnant, I was working in Oxford from London. So it's about an hour and something commute there. I'd go early in the morning. I'd play squash in the morning before work with my principal, would have a day of work. By the time I get home, it'd be like 7. So, 7 to 7, 12 hours, I'm not there. So wife's pregnant. And she says to me, Jaz, you do know that babies, they wake up around about 6, 7, and they go to sleep at 7. I'm like, holy crap. And she's like, yes, how are you going to make time for a child if you're working like this? And so I had to do something, right? So I had to do something, and that was, and I'm so glad this happened. And I left an associate position. I changed my hours, and eventually I changed practice so that now, Omid, I have a 3-minute commute.
Perfect.
We work in a practice which is shift pattern. So either I work a morning or an afternoon. It's like a 5.5, 6 hour thing. And on most days, I get to bathe my son. So for me, it's a great blessing. I'm very privileged for that. But it took a lot of hard work because I had to really desire it. Like everything is created twice, right?
Yeah.
Once in the mind and then once in reality. So the message there for anyone is like, what is it? Decide, how much do you want to earn? What is a comfortable amount for you? How can you make it happen working least days as possible or least sessions possible or reducing your commute as much as possible if your commute is burning you out?
Yeah.
And then work backwards and make it happen. You just got to make it happen, right?
Yeah, I love that so much. The reverse engineering, because I think a lot of people, they'll go to that first step, right? Like they'll be like, oh, I don't like enjoy my job or I'm working too much. But then they just leave it at that. Like they don't take that ownership to be like, no, if anything's going to change, it's going to be coming from me initiating that change. And I need to be the one who takes steps to get this to happen. And I think that's one of the dentistry in particular, like it's almost, and once you have some, maybe when you're a new grad, you have like less options in terms of jobs and, you're not as in demand as you might be, maybe if you're like an associate who has like 5 or 6, because like you as an associate are like a gold mine to the practice owner as well, right? So you have a lot of leverage in these situations when you come into the practice, like I have all these skills, I have all this network, and I can bring this to your practice. So you can have a little bit more sort of negotiating power than maybe a new grad. But if you're in this stage of life where you have some choice, dentistry is probably one of the best jobs because you can very easily be like, I want to work in this neighborhood. I'll reach out to these 4 practices. And then within a few weeks, you can have a job and you're working and you're producing money. And but I think it just takes that you need that initiative to be like, I don't want this life that I'm working like 5, 6 days, 7 days a week, whatever it is, late nights, or I'm working Saturdays. And taking that ownership, like, no, I want to work Monday, Wednesday, Friday. This is my non-negotiables. And then just working towards that, even though it might be a bit of a downturn in your income initially, and then it'll sort of bounce back and you'll recalibrate from there. But I think it takes a lot of courage at the start. But I think being someone who, you've taken the leap and start a podcast and do all these things and putting yourself out there, it's a little bit easier because you do have that mindset shift of like, I can accomplish X, Y, and Z.
And all those courses that are done behind me, like so much education. And like, sometimes you do think, oh, have I wasted money doing this course? Or have I wasted time doing this course? But ultimately, eventually you will put it to use. You should. Yeah. It's going to be stored somewhere. You got to apply it ASAP. But a lot of I've never regretted any new education or knowledge I've gained. So I think that's a bank. That's something that you can grow and grow and grow, and it'll always be useful. So always being on a path of learning new things. But one thing to mention actually, Omid, is you mentioned about a new grad may not be able to have enough leverage as perhaps someone more experienced could do. And I think that's a reality. And I think there's something to be said about the whole 10,000 hour rule, right? Like you need 10,000 hours or whatever of purposeful graft to master your skill. So I think don't feel too disheartened if you are a young dentist in a high volume practice, right? Because you need to see those cases. You need to see repetition of drilling caries, basic things, extractions, get hundreds, thousands under your belt, and then become good, and then become fast, and then you can transfer those skills when you got more experience and courses under your belt. So don't be too disheartened if you're a young dentist in a tough place, but you are seeing volume dentistry, because you can see that as a good thing and gain from it.
Yeah, I think one trap though to avoid with that situation, because I do agree with you for sure, is not to build bad habits. Because when I first started out, I was working, I'm working in this practice and high volume practices back when I was working in Canada, really busy, high volume practice. But like, I'm comparing myself to like the principal who's got 20 years of experience. So he's, pumping out like, all these restorations in like 10, 15 minutes. And I'm trying to do the same, but I'm like, I can't, because I don't have the hand skills or like the workflow or the systems in place. So I'm just doing bad work. And then that you got to stop yourself as that too. Because otherwise you get into the habit of like, oh, if he's doing it in 30 minutes, I should be doing it in 30 minutes. And then that's a recipe for disaster for new grads. So I think don't compare yourself to like people with way more experience, because it's a huge difference in that realm of like experience, your hand skills. But building those bad habits and letting your standard of acceptable work drop, especially early in your career, could be a bad thing.
And something that can happen like this, and you won't even realize it, right? Like you start cutting these corners, and then it'll become habit, and then the nurse will expect you to cut corners and not use rubber dam and this kind of stuff. And then like when the opportunity arises, and suddenly you're looking at this leveling up or stepping up to a bigger, better private practice, whatever it might be, the opportunity comes, and then maybe by then you haven't applied the high-end skills anymore, and you lose it. So you're so right, man. You got to sometimes just slow down and make sure you hone your skills. Everything will come with time, not to rush it.
Yeah, for sure. I think it's like anything in life, like you said, the 10,000 hour rules, you got to put the time into to get good at it. Even now, like, I mean, I'm sure even you have cases where it's actually an interesting thing I'll ask you is because I'm finding this because we touched on earlier about the working in a hospital and you lose your other skills and you kind of de-skill, because that happened to me. So I was doing like 18 months of just pure oral surgery. So I hadn't done like a filling or like a a crown and like crown prep in like 18 months. So now I'm sort of going through that initial frustration phase where I'm like, my hands don't do what my eyes want them to do, and I'm still kind of ramping that hand skill back up. But what I find, which is interesting, is talking about the soccer, like form is temporary, class is forever type thing. But I'm still very like form based. Like I'll have like a really good week where like everything I'm touching just like looks beautiful. I'm like confident, and then the other week I'll do like a bad filling or like just like the contour is not good. And then I'll have like one or two things that kind of cascade and my form dips, and I don't feel as comfortable like with like what I'm doing. So I wonder, like, do you still, because you've been doing this for a bit longer and more consistent than I have, but do you find you have ebb and flow of like form of like how good your dentistry is, or is it pretty consistent now?
Okay, I think now it's all about case selection. So I know where my weaknesses are, and then in those cases where it's going beyond your comfort zone, then for that thing, it's about realizing that you need extra time. I think time can do wonders for you.
Huge.
So having that
Huge
self-awareness and booking extra time to do that, and the thing that's really elevated my dentistry and all my colleagues who do it is, and I'm sure you do it as well, is taking photos step by step by step and critiquing it. So I mean, the short answer is, it is much more consistent now, because what you develop in time is protocols. Okay.
Yeah.
If this, then that, then this, then that. And once you've got protocols in place, everything becomes easier. Even your nurse, which is so important. Having a good nurse is like the most important thing ever. It can really make a difference to the quality of dentistry. Now, of course, you can have a bad day that you have a bit of a cold, or you woke up on the wrong side of the bed or whatever, and you won't be performing on your best. And that's human, and that's okay. It's okay to admit that sometimes you're not going to be at your best, and to be human with yourself. But I think I have found that the frequency of the ebbs and flows decreases with time, but you still get those bad days, and that's completely okay. And sometimes, if you do something wrong, just put it right. Do the best you can. Make it up to your patient in any way.
Yeah, no, that's great. I think that's a big thing you touched on there, is the being able to synthesize information quickly. One of my like surgical mentors at the hospital, that was like, it's like one of the underrated things of being like a good surgeon or a good clinician is being able to take a lot of inputs and make a quick decision of like, all this is happening, I need to do this. So I think that's a really good point. And that's the only thing that just comes with experience. Like you would have, I've seen this 100 times. I need to put my matrix this way, or I need to adapt my, wedge this way. And then that's like the decision-making that maybe a newer grad or a younger clinician like may not have that input, like ability to synthesize that information, and it kind of gets them stuck there.
Can I make that really tangible, that one point actually? So that you mentioned wedges and stuff. So a real great example of that is when you're starting out with class 2s, and then you want to improve your class 2s, and you want to invest in a sectional matrix kit, and then you learn eventually that actually there's no one system that's best for all cavity shapes. And then eventually you realize that until you remove that papilla, because you carry so deep, you can't actually get a decent wedge in there. So you have to sometimes go through these failures. But now with like courses and education, it can accelerate what you can learn. And even on Facebook University, people are posting step by step, full protocol cases. You can learn so much from that. So I think my challenges at the beginning, is that not knowing that I had to remove that papilla with a thermocut burr or something to allow my matrix to seat. So now you've raised a great point about that surgeon that taught you. Now these things are automatic, because I've been here. I've been in this awkward scenario before. So I know to do this, and this is going to save me 5 minutes of heartbreak. Yeah.
Even like, I remember when I first started, graduated, I would like, prep a class 2, and like, like on the like the peripheral walls, you haven't like clear the contact. So like your matrix is just like not even clearing. And I spent like 5 minutes. I'm like trying to like, now I'm just like, just cut it, just like open it.
Yep.
Yeah.
Or you're trying to cut a crown off, and then you just do a little bit, and then you see, okay, let me try and see if I can split it. But you just break the ceramic off, you still got the metal. Then you just draw some more, and then you try and break it. Just cut the whole thing off and then slip it. It's these little things, little struggles you have to go through until you remove all that metal. It's not coming off.
Yeah, no, I love that. And it's just reps. It's just reps. It's just making mistakes, figuring it out on the fly.
Reps.
And like to your point of like documentation of if you have a great memory, you'll remember it. But if not, just take like having photos and be like, yes, so if I'm doing this and this happens, I've done this and it worked successfully. Let me try that. And like everyone's got their little tools and like tricks up their sleeve as well. But just the joys of dentistry, I guess.
Omid, do you do? I feel like you're the kind of guy who would do journals and stuff. Do you journal?
I do. To be honest, it's not as consistent as I used to be in terms of like my routine with it. But I do journal. If I don't do it every day, I'll do like a sort of a weekly catch up, and I'll just review the last week and things. It's less clinical though and just more sort of just general life things and goals and all that kind of stuff, and like headspace, like where things are at. But that's probably one of the best things I've done in the sense of tracking change. And I love. One of my favorite things to do, like if I have just like some time off, is I'll flip back and I'll go back like 6 months or a year or 2 years, and I'll read sort of what like I was like my struggle was, or like what I was stressed about, or like what my goals were. And then it's cool to like be like, oh wow, that was like a thing, and I've like accomplished that, or like we got through that and survived that, or grew from that, learned from that. So it's definitely a good tool. Do you journal yourself?
The point I was going to make is, I mean, I do journal, like life journaling, which is good to do. But I think in my first 5 years, I was really good at reflecting and journaling. And when I did make a clinical mistake or something took me longer and I ran 20 minutes late, it's good to just write down what lesson you learned from that.
Yeah.
And eventually you build this bank. And just like you said, the reps, right? And I think sometimes by reflecting and journaling these, the more clinical side of things, as well as for mental health, doing life as well, like journaling is such a beautiful thing to do. But for clinical dentistry, it also has a place. And I think in the UK, we're very good at encouraging new grads to carry out being a reflective learner. So just wanted to plug that as well. I think it's a good thing to do when you're in the struggles.
Yeah, definitely a great idea. And I think understanding that like the learning curve of everything, like there'll be that initial sort of the frustration phase, and then you kind of get over that and you get that the first wave of confidence, and then there'll be like new challenge. So it's never a linear process either. You're just gonna have up and down in terms of your learning and your success with cases and things like that. So I think if you're not stressed, maybe it's a sign that you're not like pushing yourself enough either. Like you're just kind of doing, which is, like I said, there's no harm in that. But I think if you're a person who wants to be growing clinically, there will be periods of time where you have that initial learning curve and so like a bit of frustration.
I think an oral surgeon once taught me that never ever stagnate in your career.
Yeah.
Because although you said, yeah, it's okay to just coast. Like, okay, fine. If you want to coast and do dentistry within your little bubble that you're comfortable doing, that's a beautiful thing. But eventually you'll be clock watching, you might get bored. So it's important, I think, just professionally, just to inch a little bit out of your comfort zone always, even though you're like, comfortable in life, you got enough money, you want to just look after your children and you want to go home and not have to think about dentistry. Fine, fair enough. But it's still, so to keep the magic of dentistry alive, you got to fall in love with the detail and still push yourself, I think.
Yeah, I think that's one sort of main tool that I've used to kind of stick with it sometimes is, flipping my focus to the art of it, of the craft of getting better. Like that's sort of like because the day-to-day, like you might be doing the same thing over and over again, you kind of get bored of it, or it's becoming a bit mundane. And but it's like, let me focus on the craft, let me like make those incremental improvements. And even if it's like the same, if I'm not doing crazy like full arch cases and stuff, even if I'm doing a single crown, let me like get this as perfect as I can get it over the next year, and then I'll add on to that, and I'll go on to the next thing, and I'll progress from there. So I think that's like one way I've found of sort of coping with like maybe the day-to-day dentistry sort of downside. But what's your strategy for and you have a lot of positive energy, so I know you love dentistry, and like a lot of people do, but a lot of people sort of maybe don't, or they're struggling to find that sort of spark or that passion. How do you cope with like a rough day or a rough week in terms of I know reflection and journaling is one side of it, but just like, a bad patient, or you have a bad encounter with someone, or a bad procedure outcome that you didn't want. How do you what's your coping mechanisms? And do you have any tips for listeners on that side of things?
That's an awesome question. I think we all experience it. And although I've never had a formal complaint, touch wood, people, some things go wrong, and then you will get. I get sleepless nights sometimes. Okay, it hasn't happened in about a year and a half, 2-3 years now, which is great, but it's gonna come, right? Something will go wrong, and because I care, because I genuinely care, I will get worried because I care for the patient, and then sometimes dentists get some sleepless nights, and it's a reality we face every day. So how do we cope with that? I think firstly, you have to do whatever you can to get it out of your system and talk it out. So my wife's a dentist as well. Now she's a completely different dentist to me. I'm like focusing on the microns, and she's chasing children with fluoride, right? So it's like a macro and a micro at a different level. So sometimes talking it out. So whether it's on a forum of dentists or your best friend or someone, I think talking therapy, which is essentially like a form of cognitive behavioral therapy, is so good, because otherwise, the most dangerous thing that can happen in dentistry is that you start to feel isolated, and it's just you and your nurse, and there's four walls, and then you see your thoughts and your worries and your anxieties. So I think you must talk it out, and then also think about incorporating mindfulness into your routine, and that is, I think, such a great thing that's boomed in the last 10 years, and it's such a great thing to have, because things will go wrong, and we need coping strategies, and that is a really good coping strategy, I think.
Yeah, I really like that. You mentioned earlier, having a good nurse is really important. How do you find, because as an associate as well, like, in that work dynamic, you're not necessarily like their boss or like you're their employer or something. How do you work with like a new nurse in terms of training them up and getting them to work within the workflow that you want to work with? Because that's something that I've got a new nurse now, and I'm new at the practice as well, right? So I'm not 100% familiar with where everything is, so we're kind of learning together. And I thought I'm working on my leadership, because they might do something wrong and you get frustrated, right? But if you don't vocalize why you're frustrated, or you didn't give me this when I needed it, or you put out the wrong equipment or the wrong material, you need to communicate that. Otherwise, it'll just keep happening, and then you keep getting more and more frustrated and go down that sort of vicious circle. In terms of strategies or tips in terms of working or coaching up a nurse, do you have any good ones?
Yeah, I think the most important thing is what is the one thing that nurses crave, that nurses want with dentists? It is consistency, because the job of a nurse, like he or she has to set up the tray, and when you're done with the procedure, they start their next job. They have to then clean up, tidy up, and they're so key in the role, and also in comforting the patient, speaking to the patient, a huge role that they play in our day-to-day dentistry. So the thing that they find annoying is that if you are a dentist who lacks protocols, and then your nurse, he or she wants to just set things up and make you happy, but then every time you do a composite, you do it differently. You use a different composite, you use different instruments, you sometimes air braids, sometimes you don't, and you don't have a clear system, that will stress the life out of your nurse, because this is why nurses hate working with multiple different dentists, because we all do things differently. So if you want to keep your nurse happy, involve them and tell them why. So I, like, for example, when I do a vertical crown prep, my nurse knows my exact protocol and why I am not using rubber dam for a vertical, but when I'm doing an Emax onlay, she knows that I will be using rubber dam. And it's about putting in the hard work and front loading the hard work at the beginning to educate your nurse about your philosophy and why you're doing it. And you know what? It's amazing. Nurses will sometimes say to you, you know what? No dentist ever taken some time to actually explain to me why they're doing it. So I think they would love that. I think just giving some more time and respecting them and their intellect as well.
Yeah, no, that's a great tip. And I think that's something that a lot of successful dentists do. They really involve the team in treatment, diagnosis. They'll show them, they'll call them in. Like the principal dentist I work for, he does sort of like, I think, a lot of surgery and stuff, like I said. But like if something's cool, like he'll literally, like, he'll call the front desk receptionist, he'll call the hygienist, like, come have a look at this, and then he'll talk them through it.
That's
which I think it's like a really cool thing to like involve the team, so everyone's on board with the treatment and treatment outcomes and things like that.
And the patient thinks you're awesome. So this is a secret communication tip, right? Like when I have a new nurse with me, I will say, Yasmin, can you see this color of dentine is this, and this is why I etch this for 15 seconds and I don't etch this, and the patient's hearing this, and the patient's like, wow, this dentist is so knowledgeable, even though it's like basic stuff, right? Yeah. But the patient's also part of this. And you're like, wow, this dentist is taking so much care and attention, and they're there. They're like a fly on the wall. They're listening to these things. So I think it's a great communication thing sometimes to tell the nurse, but really you want the patient to hear what you're saying.
Yeah, that's a great tool.
And you see this, Yasmin, this is a really deep decay. Like this is really close to the nerve. And then when you come back later, the patient will remember.
Yeah, and they're great. No, that's a great tip. I think it's really important, that communication piece of it, and getting the nurse involved, and because it engages them as well. They're not just passively standing there like holding the suction out. Like they're like, okay, this is what we're doing. This is what the goal of the treatment is. This is why we're doing it. So great tip. All right, let's shift over to a little bit of clinical stuff then. Talk me through sort of when and why you talk to your patient or prescribe like an occlusal splint for them?
Okay, thank you for changing the term night guard to an occlusal splint. Okay.
Yes, so, I've learned.
No, there's nothing wrong with that, man. I'm just kidding with you.
No.
So that's a big high-level question.
Yeah.
Let's break it down. I think the most confusing thing for most dentists, including for me, is like which splint, when, and why. Okay. And I think the problem lies with the fact that a lot of the times, dentists, when we come to the diagnosis stage, we just write TMD. And that's supposed to be this all-encompassing diagnosis. But within TMD, there are TMD is an umbrella term, and there's so many different diagnoses within it. And I'm going to come on to maybe what different types there are and how we can manage it differently. But the big problem here is that the evidence base is really poor when it comes to TMD.
Mm-hmm.
The evidence base for splints is pretty much non-existent. Yes, there are some papers about Michigan splints and soft bite guards, some good, some bad. They'll conflict each other, but the N numbers are all low. The quality of evidence is really bad, and therefore we really struggle as dentists. So when we're at dental school, we really don't get much experience. We don't prescribe many appliances, and then we go on all these different occlusion courses, and then the occlusal splints bit is in the last 1 hour of like a 7-day continuum, and someone just says, okay, just make a Michigan, and that's it, and then don't ever make a soft bite guard. But when it comes to practice, the most commonly prescribed occlusal appliance is the humble soft bite guard. So it's like this massive level of confusion, and I think it all starts with a lack of knowledge about how to make a good diagnosis. Do you have any specific questions on that, or should we to go into?
Let's go into
any direction you want.
Let's go into the diagnosis side first. So, patient walk. So, I guess like we're gonna look at it. I think there'll be two ways that dentists look at this, right? And I'll try and frame it that way. Like one is the patient comes in with like TMD symptoms. They got pain on opening, limited opening. They got tight muscles. They wake up with headaches and things. So there's that extra oral aspect of it, maybe. And then there'll be the intro. Like the patient walks in, they got wear on their teeth. They got wear facets. They got cracks. So you're like, oh, we need to put something in to protect the teeth. So how do you break that up first? And then we'll kind of go down each, I guess, rabbit hole.
Okay, that's an excellent question, because essentially what you're leading to is two different things. So why do we give appliances? We give appliances because sometimes we're trying to diagnose something, i.e. Is their occlusion or their bruxing anything to do with their pain? If you give appliance A and their pain improves, then we can think, okay, maybe there's a link. So, or maybe you're trying to deprogram the muscles before you take a bite record, so you can do more complex dentistry. So sometimes you're figuring something out and you might give an appliance like that. So that's the easy patient. That's the easiest time, because it's a short-term appliance and we can come to Lucia jigs and whatever, all like that. But then the two types of patients you mentioned there is the pain patient and the protective patient. So the pain patients are can be the really complex ones. But if you are a clever general dentist and you look for certain signs and symptoms and then you do some basic muscle checks, you can cherry pick your cases as a GDP, and you can get really high success rates, because essentially a lot of these pain patients have myofascial pain, which is different to someone who may be having an intracapsular issue. So already, let's talk about TMD. Three main types. Now, if you look at the research diagnostic criteria, there's like so many different types of TMD, but it can be broken into three main types, which is muscular in origin, so their muscles are hurting; intracapsular, so something is happening within that small space of the condyle and the disc. So that's when someone's got like locking and popping and their jaw is catching, and you've got the limited movement due to the disc being like an obstruction, okay? And that's a different patient to someone who's just getting headaches and jaw ache, and then they're getting spasms and whatever. That's a different patient. And both of these patients are different to that patient who we see so much of, like you leading to earlier about during COVID, we see so many more cracks, so many bruxes are coming out the surface and whatnot. And a lot of these patients, because they don't realize they have an issue, it's very difficult to then suggest to them any treatment. So where does that lie? So I think the basic thing to understand is the term bruxism is almost like it's a dirty word, right? You can term someone a bruxist, but actually most people, okay, every night, most people will brux, okay, between 3 and 15 minutes a night. Okay, and it's those 15-minute plus grinders who've got the strong muscles, okay, who may be overloading their system. These are the true bruxists. And maybe they only make up less than 10% of our population. Okay, they're the ones who are cracking, destroying dentistry, having they're the ones with a huge hypertrophic masseters. Whereas most of us, we do rhythmic masticatory muscle activity. Okay, and that's acceptable. So you have to look at the age of the patient. So if you take that protective patient, look at the age of the patient. If they're 60, 55, 70, and yes, they get some wear, and maybe they haven't got that much dentin exposure, then why are we doing anything? Right? Yeah. If it's consistent. So you got to bring the age of the patient into it when you're looking at that clinical scenario. And the pain patient is a tough patient, because when pain has been there for longer than 6 months, there's something called chronicity. Yeah. Pain becomes chronic. And it's like if my finger is hurting, the pain signals are being sent from the finger to the brain. But eventually the cut on my finger has healed. But because the pain's been there for longer than 6 months, those pathways are still firing. Mm-hmm. And when we look at musculoskeletal pain in the body, like back pain, chronic back pain, there's a lot of similarities there between back pain and TMD in terms of the chronicity of pain. So pain longer than 6 months becomes more complicated. And there's no studies to prove yet saying that, okay, this type of pain, this appliance. So this is all stuff that I've learned from lots of mentors, hundreds, maybe thousands of appliances now, coloring in the splints, seeing their parafunctional pattern, seeing what kind, and lots of failures, lots and lots of failures along the way, to come up with some sort of system to decide who needs what. Yeah.
So talk me through that who needs what system, or like how do you decide that?
Okay, so I've got like a flow chart that someone could download. I think it's the protrusive.co.uk/flowchart. And I'll send you the proper.
Yeah, I'll put it in the show notes. That'd be great.
Put it, and then you can literally download the flow chart that I teach and I show. And it's got like, if this issue. So for example, if they've got bruxism, so that 3-minute grinder at night, not significant muscles, not breaking anything, then monitoring, and you might then give a simple appliance. Now, for that protective patient, okay, any appliance will work. For that non-pain patient, you can give whatever you want. You can give an upper and lower, and one of my favorites is an upper lower passive fitting Essex retainer. What I mean by passive fitting is like the technician has blocked out the undercuts. Like you don't want it to be orthodontic, like tight, because these patients won't wear it. So just some plastic between the teeth, and their teeth will be protected as long as they comply. Compliance is a whole nother issue, right? So a lot. If you go along the flow chart, then you got someone who's got myofascial pain. So if you feel someone's muscles, and people, I don't know how many dentists are really palpating the muscles, but the first thing to check is for hypertrophy. Yeah. If someone's clenching on their masseters and you feel a little bulge, that's normal. We should have that. But if you feel like an excessive bulge and a double bulge, that is hypertrophic masseters. These patients produce a very high level of force. If they've also got hypertrophic temporalis muscles, significant wear, and then when you palpate these muscles on the origin, the body, and the insertion, and you find that they're tender, it shouldn't be tender. One of the quickest and easiest things you can do is you put a finger on the patient's forehead, and you press their forehead, okay? And then you tell the patient, okay, this is how much force I'm putting, okay? Does this hurt? And the patient say, no, it feels fine. And that same amount of force you then put on the muscles. And if they start saying, ouch, okay, those muscles, just like the forehead, shouldn't be hurting, but they are. So now you're coming into the territory of the diagnoses you're making of myofascial pain. Mm-hmm. So if you've got that patient who's complaining of headaches, who's got signs of wear, who's got tongue scalloping, cheek ridging, who's got large muscles, okay, then you can kill 2 birds with 1 stone by help to manage their bruxism. And I say manage because you can't stop their bruxism by giving an appliance. That's been proven. But you can manage it by them wearing certain appliances. So my preferred appliance for someone with myofascial pain, now it's difficult to go too deep into this, but like on the whole, there will be certain exclusions and reasons why you wouldn't give it, but anterior midpoint stop appliances. Now, when I say that, do you know what I mean by that, Omid?
No, let's get into that.
Okay, so like NTIs and that kind of stuff. So traditionally these are like little fiddly little appliances, which I used to do loads of. Now I don't do so much, because you can have all the benefits of that appliance, i.e. the front teeth touching, the back teeth not touching. And I'll come on to why that's significant, but you can do it in a full archway. So a B-splint, okay? So it covers all the upper teeth, for example, but it just has a thick bit at the front, so that when the patient bites together, only the incisors are touching, the back teeth aren't touching. And everyone can do this now. If they feel their back, if you feel your masseters, Omid, bite on your back teeth, okay, all the way, and you feel your masseters bulge out, okay? Now, if you actually get a pencil or something and bite on your front teeth, you can't do it as much. Your masseters you will, but your temporalis will reduce by about 70%. So we know this from the EMG studies already. And that's all it takes. When you switch off or you decrease the volume or the noise or the amplitude of these muscles, then the patient can begin to heal. Then that lactic acid buildup decreases. And that's why patients can then move easier. And essentially, some of these patients are like you get the patient to bite down and you're checking whether the patient is canine guided or group function, right? Yeah. So you might have done this before. I mean, you get them bite together, grind left and right, and they're not moving. They're still, no, please grind left and right, and they can't move. That patient's locked in. Now, if they've got strong muscles and they're grinding and they're locked in, where's all that pressure going? It's being absorbed into their muscles, right? When you give that patient an appliance such as that one, which is essentially like an ice rink, it allows their jaw to move. It's like taking this huge weight off, and now their muscles can no longer experience resistance. And that's how, essentially, in a nutshell, how anterior midpoint stop appliances work. Now, Michigans and Tanners, which we were taught at dental school, are amazing. They can also work. But here's the problem. I mean, have you done many Michigans and Tanner appliances?
I mean, that's like the standard one you get taught in dental school, like you said. So most people would do that. Yeah.
The issue with those ones is, yes, they can work. But if you're going to do it properly, okay, you want to use a face bow, you want to get your records, then you need a patient for 2-3 adjustments. You got to charge the patient a high amount. The patient says it's bulky. And I used to hate it. I used to give these appliances. I used to charge more than £900 or whatever. 6 months later, Mrs. Smith would come back. It's okay, how's it going? And they say, you know what, I just couldn't wear it. And it's just kept in a drawer somewhere. And that's really sad. So how can we treat myofascial pain with appliances which are easier to comply with than with a traditional Michigan or Tanner, that can be cheaper for the patients and be more efficient in relaxing the muscles? Because with a Michigan splint, with a Tanner splint, they can still, on clenching, meet their back teeth together. Yeah. And for some patients who are clenching, that's their downfall.
Yeah.
So I still use Michigans and Tanners, but there are these dentists who every patient will get a soft splint. Every patient will get a Michigan or a Tanner. What I'm trying to say is there's different diagnoses, and based on diagnoses and whether the patient has orthodontics or not before, because, I know plenty of dentists who don't know about anterior midpoint stop appliances. So what they tell their patients who have had braces before is that, okay, one night wear the Essex retainer because you need your orthodontic retention, and then the second night wear the splint, right? Well, actually, you can get the benefits of that appliance, but also build in an Essex retainer.
Yeah.
So there are modifying factors as to why you would give a certain splint to a certain person. So and for the protective patient, like I said, anything will work. But then you got to be clever, right? If someone's got really high forces, you know that certain things will more likely to break, and you need to optimize the environment. So not as one splint is a magic splint for all. It depends on the diagnosis. It depends on the malocclusion. There's different types of answers depending on if they got a deep bite or not. So this is really, it can get confusing. So please do download the flowchart. But that's what I mean. It's easy just to give everyone a B splint. It's easy. Yeah. But then you'll get failures, and then you think, why is that? It's because you're painting everyone with the same brush. So what I like is putting some logic, some science, some experience behind it to come up with a little system or a solution.
What about incorporating sort of like canine guidance into the splint? So you put like the ramps in the anterior section, so they can get into like MIP, but then if they're grinding around, the posterior teeth disclude as they're sort of bruxing around there. Is that a common one you do?
Yeah, it can be a common one, absolutely. So for example, a typical Michigan or Tanner has that built in, right? So it's got the canine ramp built in, so that it essentially is promoting anterior guidance. Now, for someone who is suffering with migraines, which can be brought on by myofascial pain, then the therapeutic protocol, which was developed by the NTI group, Barry Glassman et al., Jim Boyd, is that they found that when you made sure that when they were grinding, the canines were not touching, you actually got more success with these pain patients. Because when the canines are touching, so when you're clenching on your molars, you're at 100% EMG levels, let's say. When your canines are touching, you're at 70%. As soon as you come to laterals and centrals, you're now to 30%. So you get a much bigger reduction in how hard you can clench when you don't include the canines. Now, if you include the canines and you bring them down from 100 to 70, for a lot of people, that will give therapeutic effect because it's within their now adaptive capacity, and it gives the body environment to heal. But for some patients, it's still they maybe need to be at 57%. I'm just making this stuff up in terms of percentages. But by actually getting purely incisor to incisor and not involving the canines, that might then fall within the adaptive capacity of that patient.
That's really
so sometimes yes, sometimes not.
So just like as a broad, I know this is not going to be 100% accurate, but in terms of a broad stroke type thing, if there's myofascial components to it, hypertrophic masseters and temporalis muscle, the midpoint sort of splint is a good way of decreasing that firing activation power of those muscles, and might be a good relief. If it's just purely protection, no facial issues, no headaches, no issues with the joints, muscles are fine, but they're sort of, there's some wear and tear on their teeth beyond what you would expect with normal aging and wear and tear, then you can sort of chuck in almost anything in terms of like a Michigan or like even an S6 retainer or a soft splint. Make it passive so it's more comfortable for the patient in terms of their compliance with wearing it, and that should sort of be a good sort of initial if A then B type thing as approach. Would that sound right?
Absolutely.
As a general stroke?
That's completely fair, man. That's good. That's a great summary, and I would agree with you. But when it comes to someone who's purely protective, then some dentists, some of my colleagues still give Michigans. I'm like, why are you charging this patient £1,000 for a problem that they haven't really registered yet? Because like, I don't grind my teeth. Okay, there's a whole communication bit we can talk about as well if you want. But like, sometimes something cheap and cheerful that's easy to fit, that's plastic to plastic. Okay, Essex, upper Essex, lower Essex, easy to fit. If they break it, if they lose it, it's a simple replacement. It's a good thing to do. Now, going back to that, you could even give an anterior midpoint stop appliance to someone who maybe has high forces and they might break some other patients. So I had some patients who break Michigan splints because they're contacting on the 7s and they really just crack it at that where it's the thinnest, right? So the best thing to do is you color in your AMPSs with a black Sharpie marker. And then they go home and they start grinding on it, and then they'll see a pattern. And that, my friend, is co-diagnosis. When the patient emails me a photo of their splint and says, wow, Dr. Jaz, I can't believe I grind. You were right all along. I'm like, yeah, duh. That's why you're like incisor like 4 millimeters in height. But these patients, they don't know, right? Oh, because my wife didn't tell me or whatever.
Yeah.
So when they can see it, then I think compliance improves.
Yeah.
So there's a whole element of co-diagnosis and getting the patient on board as well.
I like that. With these anterior midpoint ones, I know like you talked about, and I think we might just for the scope side of things, just not get into like the recalibration and deprogramming things. But for these midpoint ones, is that like a long-term wear as well? Like obviously you're covering the posterior, so you don't get that like super eruption and stuff if they're going to be wearing it long-term. But is that something you would prescribe as like a daily wear sort of going forward? Or is there sort of, you wear that for a little bit, if you get improvements, then you sort of switch it out to something else? How do you sort of manage that?
Okay, so for pain patients, initially I would say, okay, wear it every night. But also with these pain patients, like what we are led to believe in the past is a biomedical model of TMD, i.e. there's muscles are hurting because of grinding, and therefore when we sort that out, the patient will get better. Or there's inflammation in the joint, or the disc is stuck. If you sort that out, the patient will get better. But actually, there's a whole biopsychosocial component to the TMD. It's that pain perception. Like when you give an ID block to someone, right? The same ID block you give someone will be like, wow, that was amazing. I didn't feel a thing. And the other person, you're hovering the needle above their mucosa and they're screaming. You haven't even been in, okay? Yeah. And they're screaming. So this patient's pain perception, there's a reason why TMD affects women 9 times more than men. So hormones and genetics and all these kind of things have to do with it as well. So what I'm trying to say here is I'm trying to remember the point I was trying to make here. What were we talking about? Sorry.
How long you would like prescribe like an anterior midpoint source for like the pain patient?
So yeah. Perfect. So the variability that comes into it. Okay, so everyone is different. Their pain perception is different, right? So for pain patients, I would usually say wear it every night, but also I would make them very aware about the very harmful habits of awake bruxism. So a lot of people, without realizing, will touch their teeth together during the day. And they think, a lot of patients in the past who I've met who've got the worst forms, raging muscles, they told me, oh, they thought their teeth were supposed to touch together the whole bloody day. Mm-hmm. When you teach them that, okay, the mantra is lips together, teeth apart. Sometimes you don't even need a splint. Just that information, seeing a physio, TMD physio, massage, heat application, ibuprofen gel. That's all they need. They don't even need an appliance anymore. Because now the fact that they're not holding their teeth together for an hour a day, is going to heal them. It will come within their adaptive capacity. But alongside that, if they still feel like they need an appliance because there's also damage of evidence of attrition, then I would say, okay, wear it nightly. I'll see you in 2 weeks. Let's see how we're going. A lot of times they come back, they show me their parafunction analysis, like, wow, look, I'm grinding and my headaches are better. And I've got videos after videos of patients saying, yes, I feel great again. I didn't realize how heavy my jaw felt before I had this appliance. Yeah. Then I would say to the patient, let's taper it down now, maybe 3 or 4 nights a week, okay? And then if you get through a stressful period or exacerbated period, you can start wearing it more regularly again. And I think that's a beautiful thing, because who wants to wear this unnatural piece of plastic every night, right? I use it as a tool to break that cycle for the patient, and then let them taper it down and up and down to their clinical effect. For protective patients, again, it varies, okay? Even if they wear it 4 or 5 nights a week, it's going to be better than them grinding really hard. But you just have to taper it to clinical effect, see what it looks like every time they come in. The beauty of doing scans and then comparing the STL files, seeing how much more wear has happened is amazing. Which scanner are you using, Amit?
So we use, we have a Medit and we have a Trios, like 3-shape. Yeah. So I like the 3-shape more.
Yeah. I mean, the 3-shape's great, but the I don't know if you know, but like the 3-shape, it doesn't have any innate software to compare like one scan to a scan a year later, right? You can't do that, or maybe
I don't think so.
I haven't seen it on the software. Whereas the Medit, and here's the beautiful thing: you can get a free account with Medit. Even if you don't own a Medit, you can download the Medit Link software, and this is a really great pearl. You'll love this, right? You can import inside there any STL, okay, from 2 different scanners, 3 different scanners, whatever, and then it will give you that graph of how much wear has happened.
Nice. Okay.
So the iTero does this because it's got the time lapse function. But if you don't have the benefit of an iTero, and you want to compare STL files, then you can do that on the Medit Link. Just free download. It's amazing.
Good tip. Yeah, for sure. I'll look into that and get that downloaded. I mean, it's really fascinating stuff, because I definitely think most dentists just like really underthink the stuff. And it's just like, oh, there's a bit of wear, or you're coming in with like tight masseters or sore muscles, just buy a laminar splint, send it to the lab, they'll come back. Like don't even maybe do like a bite reg in like a CR or anything like that. They'll just kind of just take some upper and lower alginate and send it off. And that's they're sort of the band-aids they stick on everyone. So I think, and I didn't even, you opened that can of worms for me now. My mind's a bit blown, but so I'll definitely have to go through the workflow, the flow chart that you've recommended as well.
Sure.
And, I think so. Anyone interested, definitely check that out. Your courses that you do on this stuff, is it online based or is it in person?
It's an online course. It's a split course, and basically it's like 12+ hours going from the how to make that diagnosis, what are the special tests you should do, which patients should you treat, and I'm very much like GDP, like patients who are locking very frequently or have got a disc displacement without reduction, i.e. they cannot open, they're below 26, below 30 millimeters opening. As a GDP, do you really want to be treating that? Refer it on. As a GDP, we should be very good at protecting our patients, making diagnostic appliances, helping people with myofascial pain, which thankfully is the most common form of TMD, and it's the easiest to treat alongside physiotherapy and conservative care. And then, yes, there are some patients who got clicking and popping, who are maybe a Piper 3 classification, that you can still help with occlusal appliances, prevent them getting worse. So it covers all that kind of stuff, as well as all the clinical stuff, how to make it, how to deliver it, troubleshooting. So who would have thought that just on splints, you can have 12+ hours and like monthly coaching. So it's quite exhaustive.
Yeah, no, that's awesome. So I'll put a link in the show notes for that as well. Anyone interested? It's good that it's online, obviously, because then everyone from Australia and stuff can also check it out and learn from it. I think it's really useful too, and I think it's one of those things where it takes the relationship with your patient beyond drilling and filling. Like they might actually enjoy coming to see you, or they value the work, because you can spend an hour restoring this like subgingival like class 2, and the patient doesn't know any better, and they're just like, oh, that. Okay, thank you. And it's like leaving, you're proud of the work, but they don't really see the value. But if you can, help someone's facial pain, they'll be loyal patients of yours, and they'll sing your praises to everyone. So I think that's like a cool sort of additional thing you can add to your sort of day-to-day practice that will make you happier too, because you get that positive feedback from the patients, and gets you sort of going and motivated as well.
I think we owe it to our patients that when the patient comes in and in the diary it says jaw is hurting or TMD, that we don't think, my God, I don't know what I'm doing, right? So that's what most dentists like. And then sometimes like dentists will ask for my help and say, Jaz, I've got a patient with TMD, and that's all they say. And they say, the patient's canine guided on the left and group function on the right. I'm like, okay, what do the muscles feel like? Okay, how many millimeters was the range of motion? So these are the really important things that you'll be testing to come up with some sort of a diagnosis and a management plan, and knowing when to refer and when to treat. So that's essentially the crux of it. If I can give one really helpful clinical tip to dentists listening, maybe to make it worthwhile listening all this way, is soft bite guards are the most common thing in the world in terms of appliance that they describe. And so they were given a bad name by Occlusal, I think it's 1986, where you had these 10 patients. Okay, so the problem is N numbers are really low in these studies. And what Occlusal found is that when you had someone on a soft bite guard, that patients who were asymptomatic may end up becoming symptomatic, and it wasn't really great for the muscles. Whereas on the hard occlusal appliance, they got better. But the interesting footnote in that Occlusal study is that no attempt was made to balance the splint in any way, because Occlusal said it was impossible. Now, there was another study in 1996, I think it was, by Wright et al. And this was a systematic review. And it also looked at soft bite guards versus just advice versus nothing at all. And it found really, really amazing results with a soft bite guard. So why this difference? Okay, so when you look at the methodology of what the systematic review did is the following. So whereas Occlusal said you can't adjust a soft bite guard, this systematic review in the journal Oral-Facial Pain said you can, and here's how they did it. You get a 4 millimeter soft bite guard from your lab, okay? You get a blowtorch or a flame, and you melt it at the back, just all around, you melt it. You put it inside, and you get the patient to bite together until you get indentations pretty much everywhere, okay? Now what you have is a pretty much fully balanced splint. Now what you have to do is get an acrylic burr and get rid of the indentations, because if you don't get rid of the indentations, the patient's cusp will sit in it, and then that will build resistance, okay? That will make the muscles go crazy. But by removing those indentations, you've essentially created this very balanced, flat plane. So now when the patient's bruxing, you reduce the resistance. So that's how I think maybe in the paper it helped. So it found that the soft bite guard group did really well, and that was statistically significant. The advice group got better, but it wasn't statistically significant. But the people with no treatment got worse in terms of their myofascial pain. So the trick there is, if you're going to be giving soft bite guards for whatever reason, financial, whatever, it's okay. They can still help. But by melting it, by heating a little bit, and just doing some simple adjustment, doesn't take long, you might improve your success rates.
That's a really good tip. And it's a pretty easy one to do, right? You just, say heat it up, put it in there, bite together.
Heat it up. You get like a little bit of melting appearance of it, and then you just get the patient to make
you need that initial thickness just to have enough room to then go ahead and do that.
That's it. 4 millimeters, it was what was used in the study, and that's why I've been using it ever since.
Awesome, man. That's a lot. I think that's more than I thought it would be, to be honest, in terms of like how much there is to kind of take in. But I do appreciate it. I think it's important to touch on these things because I think it's an area that I personally haven't sort of put much time towards in terms of like my CPD allocation and learning about splints and things. So I think it's an area definitely that there's a lot of room for improvement, and then you can get those, like we talked about, pass those on to the patients and get better outcomes and help those patients out that way. So I really do appreciate you coming on to share that information and knowledge with us. It's been great, catching up with you. I think it was a good conversation. We covered sort of a lot of ground. We kind of went on some tangents.
Covered a lot of broad, random themes, like on my podcast as well.
But that's how I
enjoyed my chat, man. Thank you.
I don't. That's why I like the sort of the unstructured. I mean, I label it as unstructured mostly just because I don't put in the time to structure it. But the free flowing conversation, I think, is entertaining, and people hopefully got a lot of value out of that. So I really do appreciate.
You're very good at getting out of the guests. So well done, my friend.
I appreciate it, man. Thanks a lot. I wish you all the best with Protrusive Dental and your newfound work-life balance and your 3-minute commute. So enjoy it, and you worked hard for it. So why not enjoy it now?
I appreciate that very much. Thank you so much, and thank you for all the newbie dentists for listening. I really appreciate it.
Thank you for tuning in for another episode of the Noobie Dentist Podcast. Please be sure to subscribe and head over to iTunes and give the show a 5-star rating. For all show notes and to access all previous episodes, head over to www.noobiedentist.com. Have a great day.